Welcome back, Focus Learners. Let's jump right in. Today, we're mapping out the exact clinical pathway of bacterial sore throats. You know that feeling, staring at a red, irritated throat and wondering what on earth you're actually looking at? Well, you're in the right place. We're going to decode the clues, separate the routine stuff from the truly rare, and give you a crystal clear understanding of exactly how these infections behave.
Is it just a sore throat or something more? It's the ultimate question, right? It's the challenge every single parent or patient faces when trying to decode throat pain. Is it just a passing viral annoyance, or do we have a bacterial invader setting up camp, bringing a real risk of severe complications if we ignore it? Without the right map, it's just a high-stakes guessing game.
So, here's our map for today. 1. Anatomy of a sore throat. 2. Unmasking scarlet fever. 3. The differential diagnosis. 4. Testing and treatment. 5. Severe complications. And 6. Our summary and key takeaways. Let's get to it.
Section 1. Anatomy of a sore throat, the culprit and the clues.
Now, looking at the epidemiology, Group A strep, or GAS, isn't just some random year-round threat. It actually peaks strategically in late winter and early spring, and it heavily targets kids between 5 and 11 years old. But how do you actually spot it in the clinic? The classic presentation is sudden, and I mean literally sudden onset of fever and sore throat. You're frequently going to see nausea, vomiting, and those really distinct red spots on the roof of the mouth, palatal petechia. But honestly, what's equally important is what you don't see. If your patient has a cough, a runny nose, or hoarseness, the evidence strongly points away from bacteria. That usually means we're just dealing with a virus.
To try and bring some order to all this, doctors have historically relied on clinical scoring systems, things like the McIsaac or Center criteria. But let's be real, these haven't proven to be very satisfactory on their own for a definitive diagnosis. They kind of tend to overestimate the likelihood of a bacterial infection. But every now and then, the bacteria just gives itself away visually, thanks to an erythrogenic or redness-producing toxin.
Which brings us to Section 2, Unmasking Scarlet Fever, Visualizing the Infection.
This brilliantly illustrates what that erythrogenic toxin is actually doing to the body. Notice how that fine, diffuse red eruption is often described as having a sandpaper texture. It literally feels rough. Meanwhile, you can clearly see the classic strawberry tongue. This happens when the white coating on the tongue peels away, leaving it bright red with these prominent engorged papillae. It is essentially pathognomonic, which is just a fancy way of saying it's a near-perfect giveaway for this specific strain of Group A strep.
But you know, timing is everything, and the timeline of scarlet fever follows a highly specific pattern. Notice how the sudden pharyngitis and fever at day 0 are super quickly followed by nausea and that white tongue phase. Then by day 2 or 3, the fever peaks, the tongue turns bright red, and the exanthem, that sandpaper rash, emerges. Then, as we move past week 1, the rash fades out and gives way to desquamation, which is just the peeling of the skin. Following this exact timeline is absolutely crucial because it helps us separate scarlet fever from other, sometimes dangerous lookalikes.
Moving on to Section 3, the differential diagnosis, spotting the imposters. Now this brings us to a really critical part of our explainer. Because a red rash and a fever, they aren't exclusively owned by strep, so we need to know exactly how to spot the imposters. When we lay out the lineup of usual suspects side by side, those differentiating details are everything. If a patient comes in with a diffuse rash, you literally must run through this exact differential diagnosis. Scarlet fever has no prodrome, no early warning symptoms. But what if it's staphylococcal toxic shock syndrome? Well, that typically presents with a much higher fever and involves multiple organ systems, which strep doesn't do. Or what about Kawasaki disease and measles? Let's go ahead and isolate those two trickiest lookalikes.
Isolating these two really reveals some clear red flags. Kawasaki disease usually hits kids under 5, features intensely red, cracked lips, and crucially, carries a massive risk for coronary artery disease if it's missed. Measles, on the other hand, actually gives you a clear warning, a prodrome of a cough and conjunctivitis, followed by Koplik spots in the mouth. Distinguishing these from the strawberry tongue and sudden onset of scarlet fever is a high-stakes decision. It dictates completely different treatment paths.
Section 4. Testing and treatment protocols.
Okay, so once you've navigated that differential diagnosis and you suspect Group A strep, it's time for actionable medical protocols. How do we confirm the verdict rapidly and how do we fix it? For decades, we relied on 48-hour throat cultures, or rapid antigen tests that often needed a backup. But modern medicine is shifting, and nucleic acid amplification tests, or NATEs, are rapidly supplanting those older methods. Why? Because they amplify the DNA of the specific gas gene in under an hour with greater than 99% sensitivity and specificity. They are so incredibly accurate that they can often be used as a standalone test, totally eliminating that agonizing 2-day wait for a traditional culture.
Now, this management algorithm follows the exact logical pathway a clinician takes. Starting right up at the top, if the signs suggest GS and they have scarlet fever symptoms, you might just test and treat. If it's a standard sore throat, you run that rapid test or molecular NAAT. If it's positive, boom, you have your GS diagnosis and you treat with antibiotics. If it's negative and there are no viral symptoms, you rely on the accuracy of your culture or molecular test to confidently tell the patient, hey, it's viral, no antibiotics needed. It's just an elegant, evidence-based decision tree.
When we do confirm strep, the standard 10-day regimen of penicillin or amoxicillin is highly effective. But take a look at the paratonsillar abscess, or quinsy, illustrated here. The severely swollen tonsil is physically pushing the uvula all the way over to the opposite side. It's a stark reminder of exactly why we aggressively treat GAS. We have to prevent localized, suppurative, or pus-forming complications that can literally block a patient's airway. Section 5. Severe complications and chronic carriers. Which naturally leads us to our next focus. What happens when these infections spread even deeper? And conversely, what do we do about patients who feel totally fine but just can't seem to shake a positive test result? The imaging here reveals a really alarming retropharyngeal abscess in a 3-year-old. The soft tissue swelling is actively displacing the airway anteriorly. That's a true medical emergency that requires surgical drainage. It's the absolute worst-case scenario. But contrast that with the flowchart, which deals with patients who just keep testing positive time after time. Are they in constant danger of these deep neck infections? Usually no. If they're symptomatic, sure, they're treated. But if they're just carriers without symptoms, the algorithm guides us safely away from endless aggressive interventions.
And this brings us to a very real phenomenon called streptophobia, which is basically this immense anxiety from families who just keep seeing positive swab results. But here's the thing, patients who are chronically colonized are at minimal risk for complications like acute rheumatic fever, and they are rarely the source of spread in the community. Recognizing this really helps clinicians step back and reassure families rather than just throwing ineffective courses of antibiotics at what is essentially a harmless colonization.
And that brings us to the ultimate extreme intervention, the tonsillectomy. The data on tonsillectomies actually provides a very clear verdict. While taking the tonsils out used to be a super common response to recurrent sore throats, the evidence shows that by 2 years post-operation, there's absolutely no difference in the frequency of pharyngitis between kids who had the surgery and kids who didn't. Plus, there's a 14% complication rate from the surgery itself. So, tonsillectomies are simply no longer recommended for treating recurrent pharyngitis, except in highly, highly unusual circumstances.
Section 6. Summary and key takeaways.
We've covered a ton of ground today, navigating from the very first symptom all the way to chronic carriage. Let's pull all of this together with a high-yield review of the clinical pathway. Think of this as your mental cheat sheet. First, Group A strep strikes suddenly, and the absence of a cough or runny nose is your first major clue. Second, if it produces an erythrogenic toxin, you'll see the classic sandpaper rash and strawberry tongue of scarlet fever. Third, always pause for the differential diagnosis. You absolutely must rule out Kawasaki disease, measles, and staphylococcal infections based on their unique clinical red flags. Next, when it comes to testing, modern NATs are rapidly replacing older cultures, giving us those immediate, highly accurate answers. And finally, if a patient is a chronic carrier without any symptoms, take a breath. Extreme measures like tonsillectomies are largely a thing of the past.
I want to leave you with this final thought. As our molecular testing becomes increasingly sensitive, we're going to find more and more of these asymptomatic carriers. If we know they aren't spreading it, and we know surgery isn't the answer, it completely shifts how we manage pediatric anxiety and overtreatment. The future of medicine isn't just about finding the bacteria, it's knowing when to fight it and when to just leave it alone. Thank you so much for joining me on this explainer. Keep learning, stay curious, and I'll see you next time.